Your back's killing you, but the scan's clean. Serious? First, take a breath, you are not alone. Low back pain is the single leading cause of disability on the planet, ahead of depression and headache, and almost every one of us gets it at some point in life. It is that common. So the fact that it hurts, and hurts a lot, is not a sign that something rare or frightening is going on inside you. Here is the part that trips people up. In the vast majority of cases, doctors find no serious disease of the spine at all, no single broken part to point at. The pain gets put down to the ordinary mechanics of a living, loaded back. That is exactly what nonspecific low back pain means, not that your pain has no cause, but that there is no one disease to blame. So why does it hurt if the scan is clean? Because there is rarely one single thing to blame. The pain can come from discs, joints, muscles, and ligaments all at once, and your nervous system, your mood, your beliefs, and what is going on in your life all turn that pain up or down like a volume dial. That is also why scans are misleading. The wear and tear changes they show up are just as common in people who have zero pain at all. And here is the twist most people never hear. What decides whether a short flare turns into long-term pain is often not how much tissue is damaged. It is the yellow flags, worry, low mood, fear of moving, and the belief that your back is fragile and you are damaging it. Those predict a stuck recovery more strongly than the state of your discs. That is why good care treats the whole person, not just the spine. So what does ordinary back pain actually feel like? It usually sits in the band between your lower ribs and the crease of your buttocks. It changes with posture, movement, and load, worse when you bend or sit too long, easier when you shift position. Stiffness is common. What it does not do is shoot down one leg in a clear nerve line. Pain, numbness, or weakness traveling below your knee is a different problem, a pinched nerve, and it gets looked at on its own. Now the good news, and it is genuinely good. For most people the pain improves quickly over the first 6 weeks, then keeps easing more slowly out to about a year. Flare-ups are common, but a flare is a sensitive back acting up, not fresh damage, and it settles with the same active self-care that worked before. Be honest with yourself though, a real minority do develop pain that lingers past 12 weeks, and if that is you, the plan we are building still applies. Before any of that, a clinician's first job is to rule out the rare but serious causes, the red flags. Things like a history of cancer, unexplained weight loss, long-term steroid use, a major injury, or a fever. On their own, most single red flags barely shift the odds, so they get weighed up together rather than panicking over any one. But a few need emergency attention today, not next week: new bladder or bowel trouble, numbness around the saddle area, or leg weakness that is getting worse fast. To tell simple back pain apart from a trapped nerve, the clinic checks your legs, your power, your reflexes, and your sensation, and uses moves like the straight leg raise, where they lift your straight leg to see what reproduces the pain. Here's the key thing to know: no single one of these tests is reliable on its own. So the findings are read together, alongside your story, rather than trusting any one maneuver to give the answer. Which brings us back to that scan. When there are no red flags, an X-ray or MRI is not recommended for ordinary back pain, and that is a good thing, not neglect. It rarely changes the treatment, it mostly just shows the normal age-related changes everyone has, and it can spark needless worry and a chain of extra tests. Scans are saved for when a serious cause or real nerve damage is genuinely suspected. So a normal scan is not your doctor missing something, it is reassurance. Okay, it's not sinister, and you don't need a scan. So what actually gets you better? This is the part most people skip, and it is the part that works. First-line care is almost embarrassingly simple, and it starts at home. Understand that the pain is usually mechanical and safe to move with. Skip the bed rest. Lying flat for days makes you stiffer and slower to recover, not better. Keep doing your normal activities and get back to work as much as you can, even if you have to ease into it. Reassurance and staying active are the foundation that everything else is built on top of. You do this yourself, before you need anyone. The best supported active treatment is exercise. and one of the most studied is the motor control, core stabilization exercise, gentle work that switches on your deep trunk muscles to control the spine. You need no equipment and it is done at home after a bit of coaching. A typical program runs 1 to 5 sessions a week, for anywhere from about 3 weeks up to 12 weeks, working at a level that gives a mild ache that settles, never a sharp pain. Build up gradually, and remember, no single type of exercise wins, so the best one is the one you will actually keep doing. What about the hands-on stuff, a physio manipulating your spine, a massage, some acupuncture? Here is the honest picture, each gives small, mainly short-term relief. They are real, but modest. Think of them as helpers that make you comfortable enough to get moving, best used alongside your exercise and advice, never as a passive substitute for staying active. If a treatment only works while someone is doing something to you, it is a booster, not the plan. Mind-body classes are worth a mention too, yoga, Pilates, Tai Chi. They blend gentle movement with breathing and relaxation, and the evidence puts them on par with other exercise, small to moderate relief. There is no magic in the label. If you enjoy a class and you will keep showing up, that adherence is the real medicine. Pick the movement you like. Now, if your pain lingers, or you scored high on those yellow flags, exercise alone may not be enough, and that is not a failure. This is where care that adds support for stress, fear and beliefs comes in, cognitive behavioral approaches, pain education that retrains how you read the pain, and team-based rehabilitation. Combined with exercise, that package works better than exercise or medicine on its own. Your mind is not the enemy here, it is part of the treatment. So where do medicines fit? They are a short-term aid, not the cure. Anti-inflammatory tablets, NSAIDs, give a small, brief drop in pain, roughly 7 points on a 100-point scale versus a dummy pill, and they are the usual first choice at the lowest dose for the shortest time. Muscle relaxants can help a little short-term, and duloxetine helps some long-standing cases. Plain paracetamol on its own is no longer recommended. And the less is more part, strong opioid painkillers, steroid injections, and surgery are not for ordinary non-specific back pain. With opioids, the small benefit is outweighed by the risk of harm and dependence. So let's pull your plan together. Ordinary low back pain is common, it is real, and it usually gets better. Movement is your medicine, a normal scan is reassurance rather than dismissal, and most of what actually helps is in your own hands. Stay active, do the exercise you will keep doing, and mind the stress and fear as much as the muscles. Medicines and hands-on therapy are short-term support when you need a boost, not the main event. You are not fragile. You are built to move. One last thing. This video is general information, not a substitute for seeing a clinician. If your pain is severe and not settling, if it shoots down your leg with numbness or weakness, or if you notice any of those red flags, new bladder or bowel trouble, saddle numbness, fever, get it checked without delay. Otherwise, trust the plan, move, stay calm, and give it time. If this helped, subscribe and follow for more plain English guides that put you back in charge.